So the analysis, the cytokines was a plasma analysis at the time of the fistula creation, was from blood taken from at the time of the fistula creation.
Okay, at the time of creation, okay.
Yeah, the genes that we analyze are from the tissue, from the vein, process vein.
And do you think somebody looked at the beginning, after the fistula is created, sampling from the venous side, do you think that would be more enriched of potential specific biomarker rather than systemic samples, plasma samples? Mm-hmm.
That's we are actually working on that, so we'll see in the future.
Thank you.
Juan, thank you very much for that excellent presentation. We'll move on to our next speaker. Dr. Lloyd, please introduce Dr. Jonczak.
Perfect. All right. Hello again, everyone. So next, I have the privilege of the honor of introducing Dr. Emily Jonczak as the next grand round speaker. Dr. Emily Jonczak is a board-certified oncologist, assistant professor, and the inpatient medical director for medical oncology at the University of Miami Sylvester Comprehensive Cancer Center. She completed her medical school at St. George's University School of Medicine, followed by her residency at Cleveland Clinic and subsequently her fellowship in hematology oncology right here at the University of Miami, where in her final year she served as the chief fellow of hematology oncology. Dr. Jonczak is a member of the Connective Tissue Oncology Society, the American College of Clinical Oncology, and the American Society of Hematology. She has published several book chapters in the field of medical oncology and is actively involved in several research studies, most recently involving the testing of the anti-cancer drug rogaretinib for treatment of advanced sarcoma and in patients with SDH-deficient gastrointestinal stromal tumors. Dr. Jonczak is a beloved attending in her field, and it is my great pleasure to introduce her as our next grand round speaker.
Thank you very much for that. Okay, so we'll get right in. We have a lot to talk about. So today our goal is we're going to talk about an overview of sarcoma in general, the current standard of care for diagnosis and treatment options, and then we're going to get into an introduction and discussion of where the field is going with precision medicine and sarcoma and some of the clinical trials and work we're doing here at Sylvester. So first, as we all know, cancer is still the second leading cause of death in the United States. And what I wanted to highlight here is looking at things like, for example, breast cancer, where over 260,000 women will be diagnosed with breast cancer on an annual basis. But in soft tissue sarcoma, on the other hand, we're only around 13 to 14,000 patients per year. And in our bone sarcoma patients, around 3 to 4. And approximately 6,000 patients will die on an annual basis from a sarcoma. So what does this mean? This means that we're dealing in the ultra rare. Only 1% of all cancers will be a sarcoma. And there are many, many different kinds. In fact, over 170 different kinds that on the, I think according to the WHO, most recent update, it was 175 different types of sarcoma. So what is sarcoma? Sarcoma comes from the Greek word fleshy, meaning it's arising from mesenchymal tissue or connective tissue. This is just obviously not an exhaustive example, but some of the examples of sarcoma that we have, they come from bone, muscle, cartilage, nerves, blood vessels, and they can occur anywhere in the body. And again, there's 175 different kinds, and they behave differently and require different treatment options. Where do they come from? In most cases, we don't know. So in most cases, we don't have a clear understanding, but there are some hereditary and genetic predispositions. The most leading one to think of would be Li-Fraumeni syndrome or germline mutation in P53. Patients can develop various sarcomas, commonly osteosarcoma with that. Others to highlight is patients with neurofibromatosis type 1. That's pictured in the picture. And these patients can either develop de novo malignant peripheral nerve sheath tumors, or from their neurofibromas, they can actually transform into malignant peripheral nerve sheath tumors. And it can be very challenging to diagnose and treat these patients because on imaging, they'll have multiple lesions, and it can sometimes be difficult to see what's benign and what's not, and what's malignant. And then I'd also highlight FAP, which has an association with our patients who develop desmoid tumors. And so any patient that comes to my clinic and is diagnosed with a new desmoid tumor, I screen them for FAP. Again, they can occur anywhere in the body. Most commonly, they'll be in the extremities. Second leading location would be the abdomen, pelvis, and then 15% in the retroperitoneal, and the final in the head and neck. And how they present really is dependent upon where they're located. So patients who come to us with masses in the extremities, they usually often will be paying less until it starts to cause potentially compression on the nerves, or if the skin gets really pressed, because these tumors can grow to pretty big sizes, and that's when they'll start to present with symptoms. In the intra-abdominal cavity, often patients will complain of abdominal distension or bloating. Sometimes they'll have early satiety. And in other instances, they'll only present after another organ starts from obstruction. So for example, patients might develop compression on the ureter and develop hydronephrosis and present to us with abnormal kidney function. The standard how we deal with these, MRI imaging is our imaging of choice, especially in the extremities. It gives us a better understanding of the soft tissue and structures. And then to stage them, we often do a CT scan. And here the gold standard is core needle biopsies. I can't emphasize enough, if you ever come across one of these in clinic, FNA is not enough, if I haven't said it. Again, there's 175 different kinds of these. And so we really need enough tissue in order for our pathologists to run tests and really just determine what we actually are dealing with so that we can treat them. I can't tell you how often in clinic we see patients that just come with spindle cell neoplasm, and we certainly need more information than that. And then lastly, staging. The thing I like to highlight about sarcomas that's unique to other cancer types is that we also grade them. So most cancers use the TNM staging system, tumor, node, and metastasis. And sarcomas also add in a grade. So what the grading system is essentially the pathologist is looking at the tumor, and they are looking at how abnormal they look, how quickly they appear to be dividing, and they assign a grade to it. So in other words, 1, 2, or 3, or low, intermediate, high, which does determine, it does affect prognosis, and it does affect how we treat them. And then just to comment on sites of metastatic disease, we know that the most common site of metastatic disease is lung. So in all of the patients, they should have staging imaging of their lungs, but it can be anywhere, lung, liver, as I listed here. Rarely lymph nodes. Actually, the sarcomas listed there are the only sarcomas that spread to the lymph nodes. So if you see lymph node enlargement with something else, it probably isn't their sarcoma. It may just be inflammatory. And conventional treatments. So currently, it's very important for patients to be sent to a tertiary treatment center where they can have coordinated care, because we work very, very closely with our radiation oncologists and surgeons to treat these patients. Obviously, in the metastatic setting, the medical oncologist takes the lead, and those are treated with chemotherapy. But in the local setting or locally advanced setting, we use all 3 modalities to treat these patients. We like to start with the chemotherapy, largely for a couple of reasons. It gives us an idea of, one, the patient's tumor biology, because again, even though a patient can have a leiomyosarcoma, they can behave differently among patients themselves. So there's many different kinds, and there's heterogeneity within the sarcomas themselves. So when we can give the chemotherapy up front, it gives us an idea of how well that patient's going to respond to it. They may have shrinkage of their tumor. They may symptomatically improve if they've had pain. It also can help us downstage the patient so that they can undergo a limb sparing procedure rather than an amputation. And it also treats reduces the risk of metastatic disease and locally recurrent disease. Here at our institution, we tend to do radiation following that in the before surgery setting. And then finally, we remove these with wide local excision with negative margins. So this is by no means an exhaustive list of our active agents, but it does give you a few things that we use. I highlight adriamycin and ifosfamide because those are our backbone of treatment for most of the sarcomas that we're going to give chemotherapy to. And then the rest of these can be used in 2nd and 3rd line. Another important thing to know about what we currently do is that these tumors respond differently. So it's important, again, our pathologist is our best friend, because it's important to know what sarcoma we're dealing with, because they respond differently to the chemotherapy. Some of them are very responsive, for example, Ewing sarcoma and rhabdomyosarcoma. We can downstage these. I actually had a patient with Ewing operated on today where the surgeon couldn't even find the tumor because he had responded so well to his chemotherapy. And then they vary, and they can be minimally sensitive to even resistant to chemotherapy. So moving forward, that's what we that's what we do now. So moving forward to what can we improve on? What can we do better to treat these patients? So there's a move in general oncology towards precision medicine or targeted medicine, as well as using things like immunotherapy. And what does it do for us? Well, we've developed the technologies now that we can do molecular and genomic testing on patients in the clinic practice on a daily basis. It helps us to understand and give tailored therapy in later lines for these patients. It helps us understand the landscape of mutations of the patients we're treating. We can develop clinical trials where we match patients. When I was introduced, they mentioned the FGFR trial. That's a trial that we're running here at University of Miami, where patients can be enrolled in 2 arms. If they have a mutation in the FGFR, then they can be enrolled regardless of their histology. And really, it's a paradigm shift in how we think about treating and enrolling patients on trials. So sarcomas are challenging when we look at the historic data and the historical clinical trials, because they're all comers. So whenever we're testing chemotherapy, it's any patient with metastatic sarcoma gets enrolled. That can be difficult to interpret because, like I mentioned a few slides ago, patients respond differently to chemotherapy, and even within sarcomas, there's heterogeneity. So if you're looking at a rhabdomyosarcoma, which is very sensitive to chemotherapy, and looking at that versus someone who has something like conventional chondrosarcoma or sarcoma coming from the cartilage, which are resistant to chemotherapy, but those patients are on the same trial, it can become difficult to really interpret that. And we have to look at those trials with a very keen eye, but that's what we have, because again, we're in the business of rare diseases here. But with precision medicine, we have the opportunity to tease that out a bit more. So now we can look at patients and we can do design trials that are directed towards particular mutations. So they can be even tumor type agnostic, and just if you have an FGFR mutation, you can be enrolled on it. Or we can start to group diseases together that seemingly behave in a similar way in order and develop trial designs that group those diseases together. So for sarcoma specifically, we know by doing these testing, this is just a brief list of some of the mutations and gene amplifications and deletions that we see and potentially can target. Point mutations in GIST, which we'll discuss briefly, in dedifferentiated liposarcoma, which we're also going to talk about with MDM2 and CDK4. So these all potentially give us an opportunity for trials and furthering treatment. I'm going to touch on GIST. This is not going to be a lecture on GIST, but I'm going to highlight it because this is our golden baby of sarcoma and precision medicine. GISTs are the most common GI sarcoma, but they only account for 0.2% of all GI tumors, but 80% of the GI sarcomas that we see. They can behave, historically it was just surgery and chemotherapy, but these have a high frequency of metastatic disease and coming back, and were very traditionally difficult to treat until we discovered a KIT mutation in them. And when we discovered that these patients had this KIT mutation, it was around the time that they were developing Gleevec or imatinib for CML. And it was actually a wealthy patient who was able to pay for the medication. This patient was abroad, and they gave her imatinib as the first treated patient, and they saw an amazing response, and that led to a clinical trial. And why I say it's our star is because of our understanding, we now have 5 FDA approved medications for the treatment of GIST, which is unbelievable in a very rare tumor to have that. And then with that, we know that the landscape is even broader than just the KIT mutation, and we've been able to develop and run trials to find other directed medications to treat these tumors. And lastly, I want to say this about GIST is that KIT testing or molecular testing in GIST now is essentially equivalent to hormonal testing in breast cancer patients. And if you're not doing it, then you're not appropriately treating these patients. And unfortunately, when we look at the data across the United States, only approximately 30% of patients with GIST have their tumor tested. And we see this in clinic all the time with patients progressing on imatinib or second line TKIs and have never had their tumor tested. So we're sending the message to hopefully improve this in the future. So moving forward, now to talk about some of the work we're doing here, specifically in liposarcoma. So we'll touch a little bit. Liposarcoma is a sarcoma that develops from fat cells. To kind of go over the spectrum, we have lipomas, which are benign fat masses that you can just leave alone. and then atypical lipomatous tumors and well-differentiated liposarcomas, which are essentially the same in terms of looking at them under the microscope. They're low-grade sarcomas. They're named differently because of the location. So it's an atypical lipomatous tumor when it's in the extremities, and it's a well-differentiated liposarcoma when it's in the abdomen or retroperitoneum. And then the most aggressive of this is referred to as dedifferentiated liposarcoma. This is an intermediate high-grade sarcoma. And these are the ones that grow quickly. They tend to be very large, and they have a propensity to spread to other parts of the body and to recur. So we know that we don't fully know the incidence of them because, again, they're rare, but we do think they account for approximately 15% of sarcomas. They're strictly in middle-aged and elderly adults. It's very rare to see these in children and adolescents. There's no race or gender predilection. We don't fully understand risk factors for it. They've looked at BMI and obesity, and there doesn't seem to be an association there. And again, they can occur anywhere in the body. When they're in the abdomen and the retroperitoneum, they can be very, very large tumors reaching above 30 centimeters in size. Again, imaging. This is a good image to highlight this because this whole thing is sarcoma. If you can see my arrow, I'm not sure. The solid part that the arrows are pointing to are the dedifferentiated component, and the part below that is what would be considered the well-differentiated component because it looks like fat on scan. And our current treatment options, when able, surgery is still the mainstay when we can remove these and have a complete resection. However, the recurrence rates remain high despite a negative margin surgery. So in patients who have them in the extremities, those are typically well diff. So again, the lower grade tumor, and they tend to be a little bit, have a little lower recurrence rate. However, the patients who have them in the abdomen or retroperitoneum can have upwards of 50 to 60% chance of this coming back. I have patients who've had 5, 6, 7 surgeries trying to remove their disease. And unfortunately, they tend to be morbid surgeries because these are large tumors. They often have to remove organs. So patients will have nephrectomy, part of the bowel will be removed. Sometimes they have to have a Whipple procedure. So they tend to be very morbid surgeries. We also have utilized radiation therapy to treat these. Oftentimes here we like to try to do it if we're going to do it in the pre-surgical setting when possible, because obviously when you're radiating the abdominal cavity, there's vital organs that we don't want to have toxicities to, like the bowel. So the tumor can sometimes serve as a buffer to minimize toxicities. But our surgeons and radiation oncologists here also work very closely together. If there's a positive margin or macroscopic gross disease left behind, sometimes they can target that as well. And then of course, chemotherapy. In the current standard, there's no standard chemotherapy for well-differentiated liposarcoma. However, with dedifferentiated, we do use doxorubicin, or also called adriamycin, as our backbone. And we often combine it. If we get them before surgery and they have both their kidneys, we like to give ifosfamide. If they're frail or have abnormal renal function, we can give a medicine called dacarbazine. And we do like to give patients who have large tumors with dedifferentiation chemotherapy, because we know that those grade 3 tumors have a metastatic rate of up to 33%. And then in the metastatic setting, because these patients can also present in that way, we also, at the current standard of care, give them chemotherapy. So again, it's still a doxorubicin backbone. And we combine it with, if we are able, ifosfamide. We also will combine it with the dacarbazine. We know that the doublet is better than the single. So we know that the objective response rates nearly double when we can combine the chemotherapy from when we can give single agent. And then when we get into the second and third line, we have other agents with, marginal response rates, but this is an area where we hope we can do better. So liposarcoma is a primed one to be hopefully another good example of precision medicine with sarcoma, because a hallmark of this disease is this molecular aberration. It's almost pathognomonic in this chromosomal amplification that leads to 2 key genes that are amplified, the MDM2 and CDK4. MDM2 is virtually amplified in 100% of liposarcomas. And if you don't see that, if it's not there, then we really need to talk to pathologists because they might have the diagnosis incorrect. And CDK4 is seen in about 90%. So CDK4 was the one that was looked at first because we had a drug on the market already from our breast cancer colleagues. So palbociclib, also known as Ibrance, is used in hormonal positive breast cancer patients, and it's a CDK4, CDK6 inhibitor. So this was looked at, it's in a phase 2 open label design where patients were enrolled from Memorial and Sloan Kettering, treated with the standard dose that's given in the breast cancer patients. And they did see a median progression-free survival benefit. And that benefit was the best within the patients who had the well-diff or lower risk disease. However, but this data did get it to where it is now on the NCCN guidelines in the treatment of this disease. So moving forward to MDM2 and the P53 pathway. So we all know that the P53 pathway is involved when there's cellular stress. So the P53 is upregulated when there's DNA damage or hypoxemia, and that is in a normal intact pathway helps with apoptosis and DNA repair and prevention of cancer. When the P53 pathway is aberrant, however, that is a way that we know that carcinogenesis occurs. So in the MDM2, it's a negative feedback loop. So when MDM2 is amplified, then that P53 is suppressed, and there is proliferation and development of cancer cells. So it makes logical sense that we can then start to look at MDM2 and develop MDM2 inhibitors. So we're currently doing that. We're here at University of Miami. We have the clinical trial. It's called the RAIN trial. It's a multi-center phase 3 trial with milidamentin versus our control arm, which is trabectedin, for patients with dedifferentiated liposarcoma. They have to be unresectable or metastatic, and they have to have had one prior line, and that prior line does have to include doxorubicin as our backbone. And on this trial, we're currently enrolling. We have patients on trial here already, and it's a 1-to-1 design to the milidamentin versus trabectedin, and the milidamentin is an MDM2 inhibitor. So the idea being that by inhibiting that MDM2, we're going to increase P53 activity and hopefully have resultant anti-tumor effects. There's been shown benefit in the phase 1 and phase 2 trials already. And the control arm of trabectedin was chosen because this is an FDA-approved medication in second line and beyond. It was approved based on a clinical trial that was with trabectedin versus dacarbazine. And there was a progression-free survival benefit of about 4 months over 1 month from dacarbazine. So we need better agents. And the objectives of this study is to hopefully look for progression-free survival and overall response rate with the MDM2 inhibitor. So we're excited about that. And then other forward directions. Here, I just wanted to highlight the clinical trials we have within our sarcoma group here. I don't even think this is an exhaustive list, but it's a good number of them. And one thing I would mention about them is that the majority of these are either histology directed or directed at some mutation or precision idea. So really changing the focus of how we're doing things and trying to make sure that we're not just doing all comers, but really trying to direct this in a way so that we can make advances. And then my other area of interest and another area we're trying to develop in sarcoma is with immunotherapy. Unfortunately, to date, with immunotherapy, we haven't had quite the same success that other cancer types have had. However, that we have seen some signal in patients, particularly dedifferentiated liposarcoma being one, pleomorphic sarcoma, angiosarcoma from blood vessels. We do see a signal that immunotherapy has benefit. And we also know from prior studies that chemotherapy is immunogenic. And so the idea of trying to combine chemotherapy with immunotherapy to try and improve the immune response is definitely being looked at. It's something that's been looked at in other tumor types and is already being employed. And it's also been looked at in sarcoma. So there's already been a phase 1 trial combining pembrolizumab with doxorubicin. However, unfortunately, the objective response rate was not met. So it was felt to be a negative study. However, when you look at the study more clearly, there's a few things that we can highlight that were problems with the trial. One, they used doxorubicin alone. So as I've said multiple times, we in our healthy patients, we use it as the backbone, but the doublet is better than the single. And we know that we use combined chemotherapy in patients. And they also didn't do histology They did all comers. So they, again, used patients who we know to be resistant to chemotherapy were enrolled in the trial, which of course their benefit is going to be lower because they don't respond to chemotherapy to begin with. So we here are developing an investigator-initiated trial where we're combining cytotoxic chemotherapy with anti-PD-1 agent, pembrolizumab. We are going to use our combined regimen, and with pembrolizumab, we are going to enroll. We're in the process of developing this clinical trial with the pembrolizumab, and we're going to enroll histologies known to be sensitive to chemotherapy. We're going to exclude patients who have resistance to chemotherapy. And we're very excited to move forward with this, and hopefully we'll have positive results and positive benefit from getting the improved immune response with combined medication. So that is all. And I'd like to lastly thank my sarcoma team. I have an amazing group of people, an amazing group of mentors, and Dr. Trent and Dr. D'Amato, and really helping build my career and move things forward. So thank you, and thank you for having me.
Thank you, Dr. Jonczak. I think we all woke up on Tuesday morning to a world that I would never have imagined, where rectal cancer was absolutely cured by a drug in a very small trial. Now, I know sarcomas are not rectal cancers and vice versa. And so therefore there are different challenges and different sensitivities, but the possibilities, of course, on the horizon are really mind-boggling. My question for you, though, is with such a relatively rare cancer and with a menu of 14 different or more different protocols that you can put patients through. I know there's subtle differences among them all. How do you decide which trials that you want to do here at Sylvester? I understand, of course, that we want to offer everything to all our patients, but I guess there has to be some sort of limit. What goes on in your calculation as to which trials you really want to do?
It's a really great question, and you're right. It's very, very challenging. I think, we as a group, when we put things together, we look at one, our population here of what we see a lot of. So we do run a lot of GIST trials because we see a lot of GIST patients. We also choose based on the quality and the study design. So we don't choose any trials that have a placebo arm. We don't choose any trials that haven't given doxorubicin or have some doxorubicin component to it, because we think that that's standard of care and we know there's benefit. And then we choose on, our area of interest. I think that for us, for me, if you can't tell, I think moving things forward in terms of precision and looking at molecular profiles and pathways, I think is really an interesting where it's going. So when we have the opportunity to explore those more thoroughly, I think that inspires some interest and desire to run those trials.
Thank you. Does anyone have any questions? Well, wonderful. I want to thank both our speakers today, Dr. Jonczak and Dr. Duque, for really great grand rounds. And we'll look forward to seeing everybody next week, which will be the final grand rounds for the season until September. Everyone have a nice day. Thank you. Be safe.